Hello, this is Dr Helen and Welcome to our GenderGP podcast, where we will be discussing some of the issues affecting the trans and non-binary community in the world today, together with my co-host, Marianne Oakes, a trans woman herself, and our head of therapies.
Thanks, Helen. Thanks for having me on. My name is Halpin. I am the founder and the manager of the This Is Me Transgender Healthcare campaign. So what we do is we fight for best practice, person-centred healthcare for all trans and non-binary people in Ireland, and we continue to do that every single day of the year.
Brilliant. So, okay, and what do you mean by best practice? What do you mean by person-centred? Unpick those things first. What does that actually mean in everyday life?
So in Ireland, the one service that provides healthcare to trans and non-binary people, they operate off a model of care that was created solely by the clinic themselves. There's no evidential basis for their model of care, and it's very much a psychiatric model of care. So we strive have international best practice model of care introduced into Ireland, which would be, in our opinion, WPATH, the World Association for Transgender Health, based on an informed consent model, so that people are believed as opposed to having to prove themselves. So this is what we strive for in Ireland, and person-centred being that the person themselves are at the forefront of their own treatment, and not decisions being made by, like I said, psychiatrists' opinions of what these people are.
Well, certainly, Marianne, those values are very, very close to, I can see you smiling there, very, very close to the attitude of GenderGP, really, isn't it? What do those words mean to you, best practice and person-centred?
If I'm honest with you, I was going to say, it sounds like you've been reading a GenderGP script there, because that's exactly what we're about. What was going through my mind when you was talking, though, was how you're finding affecting change. Are people open to listening and believing, or are you finding that there's resistance?
What I find mostly that obviously the trans community are very much on board and want change. A lot of families of young trans people are similar and want change. I'm finding a very kind of 50-50 split down the middle when it comes to politicians. I work very closely with some politicians, and some want change and some absolutely don't. But at the end of the day, in Ireland, it's not down to politicians and it's not down to trans people. It's down to our health service. So in the UK, you would have the NHS. In Ireland, we would have the HSC, which is the Health Service Executive. It's just our national public health service. So, at the end of the day, it is down to them to change things. And, as many people involved in trans healthcare would know, there's a huge amount of politics involved. And, I would say the majority of people in the HSC want change, but there's a few things that are preventing them from making that change, and it's all very, very much internal politics of individual staffing members.
Yeah, that's interesting. So you mentioned a couple of stats there. So 50-50 politicians you feel want change, and then the majority of HSE want change, but there are a small group of people who have real power. And I think we've talked about that before, haven't we? Marianne, this pyramid effect, where a single person who has very, very strong views in a position of power can have such an influence on so many policies and protocols and people, in the pyramid below them. And it's really scary and sad. But I have to say, to hear you say the majority and 50-50, I mean, those are actually quite good numbers. Do you think those numbers have changed over the last 5 years? Is there a positive shift or a negative shift, would you say?
Yeah, Helen, I think there is a positive shift. The model of care that's currently being used, there was many meetings about this model of care in 2014, 15, 16 in Ireland. When it was spoken about last time, the model of care that was agreed on didn't end up being the model of care used. It never filtered down to practice, although it's still on paper what's used and might not being used in practice. But, it's positive knowing I've been at the table at, national committee level. I've been at the table with our minister at the table with our health service, and Mostly the people that are dealing with this are on side and want change. I'm not quite sure if they know exactly what change they want, but they want change from what we have now. The problem is that, with a lot of things, Ireland is very small. Our health service is very small. Everyone knows everybody. The particular problem in trans healthcare in Ireland, unfortunately, is a problem that has previously won a court case at the Workplace Commission. So our National Health Service are terrified to go anywhere near him. And he's the person that created this model of care currently being used. So although our health service is on side, our health service, behind closed doors will say to me that they want him out, can't do anything. He's won a Workplace Commission court case once before, and they just feel like they can't touch him.
Yeah, that's sad. It's again, the words that you described there, that terrified and behind closed doors. It shouldn't be the way, but we hear of that fear all the time. And again, someone having that power. And it's so interesting that this model of care, which was created so long ago, I suppose at least you're having discussions. I'm trying to think the last time that our model of care in the UK had any kind of near that discussion. I think, the NHS model of care has been in existence for a very long time. And I'm not actually even seeing any movement to change. I don't know about you, Marianne. You've been through the system yourself, but...
My understanding is that the CPD that clinicians go through is all within the NHS in the UK. They don't look outside of the UK. So like you're saying, Noah, about the WPATH guidelines, why is the NHS or the HSE not adopting them? Why would they not adopt them guidelines? And I think, at least you're having a discussion about it in Ireland. In the UK, so I don't know, but like Helen said, I'm not hearing that there's a discussion. If there's any discussion, it's to keep it a mental health issue, which clearly it isn't. Being transgendered in and of itself is not a mental health issue. That's what they seem to want to do. How did you get involved? How have you got so deeply rooted in this to get so far? Are you from a health service background, if you don't mind me asking?
I love this question because my answer is the exact same, in that I'm an absolutely, completely 100% accidental activist when it comes to trans healthcare. When I started this in Ireland, I never wanted to be, nor thought I would ever be, the poster boy for trans healthcare. And it's quite an interesting story as to how it started, and it involves 2 bottles of wine and being very angry.
Where's the way?
I was on the waiting list for the National Gender Service here in Ireland for 3 years before I got a phone call to say that my referral had been lost for a 3rd time in that 3 years. And I got off the phone, I went and I bought 2 bottles of wine, and I just sat at home and I got drunk. And I decided in my angry, drunk trans man state to organise a protest on Facebook. And I've never done it in my life. I didn't even know how to run a protest. And I woke up the next day hungover and embarrassed and saying, oh God, I better go and delete this. And when I clicked into the event, there was 400 attendees already ready to go. So, I figured that this is something that's needed. Went ahead with the protest, got about 400 attendees at that. And then I said, this can't be a protest. This has to be a campaign. Keep going. It's too important.
And so you talk about the person-centred bit. Do they have any trans people in the service, as a service provider? Doctors, nurses, counsellors, anything? No.
So recently, I was the Irish Government Minister for Health appointee on the National Transgender Healthcare Steering Committee. Most recently, the committee concluded in January 2020. And part of that report recommended that a service user joins the governance committee and of the National Gender Service. They've recently met, and TENI, the Transgender Equality Network Ireland, have been given a seat on that, despite the people given a seat not being in going through the service. So they don't have any influence from any service users whatsoever in the National Gender Service in Ireland.
Wow. And that's all. Since I started in this field, 5-6 years ago, it's a recurring theme: is stop letting cisgender people make all these decisions. And, you know, if we took the cisgender people out, then all those things that you talked about in terms of having to prove yourself as being trans, having to prove that it's the right thing, the prove that you're going to be a trans person for the rest of your life, prove. It's like, no, just listen to me. I am telling you, I'm trans. Right. Okay, let's move on from that, shall we? Kind of thing, you know. And I think it's really important that the trans people's voice is what is heard and not locked behind closed doors, Noah, as you were talking about.
This is what I'm saying, Helen, about, you know, this model of care that's non-evidential based, that was created by one psychiatrist individual at the National Gender Service. You know, a lot of the assessment, the psychiatric assessments questions, and in Ireland you must as standard go through 2 psychiatric assessments before even being considered to be put forward to endocrinology care. And most people are, you know, given more than that. But those questions that you're asked are very hypersexualized. It's very, a lot of trans people in Ireland would say voyeuristic, often asked about what kind of porn you watch, about who you've had sex with, what sex acts you perform and are performed on you, and how you feel about it when it's happening to you. You know, all these things that are absolutely nothing to do with your gender identity whatsoever. You know, whatever porn I decide to watch on my computer has no relevance to my gender identity. Whatever sexual acts I perform with my partner has no relevance to my gender identity. As well as being questions, you know, to describe your life from birth to date, you know, taken back to any traumas, abuses, things like that. You know, as if my parents separating when I was 14 has anything to do with the fact that I just happen to be transgender. You know, it's really irrelevant, and it's only getting worse. You know, as they say, comorbid conditions, anything at all that's admitted, such as if someone happens to have, I don't know, autism or borderline personality disorder or ADHD, they're being delayed treatment for further psychiatric assessment. And we both know it's not mutually exclusive. You can be autistic and be trans at the same time. You can find personality disorder and be trans at the same time. Whereas the as being something that influences your transness, which of course isn't a word. That's what we're dealing with our psychiatric service at the National Gender Service.
The questions are making me shudder quite a lot, I have to say. Are they published anywhere? Has anyone ever said, right, I've been to the clinic and this is the list of questions that I was asked? Has anyone done that?
There's no list, but I personally have, I believe I'm the only person in the country who has a recording of someone else's psychiatric assessment. A trans woman that I know decided to record secretly her session. I've had it for the past year, so I'm still deciding what I'm going to do with it, what's the best way to use it, and how to protect herself. So I believe I might be the only person in the country that does have a recording of one of these assessments.
Coming back to person-centered approach, the reality is the person is the patient is the expert in with their own experience. The trouble that and again, this might seem controversial, but having a lot of cis people trying to work out whether we are worthy of treatment or not. Everything you said there sounds like cis people trying to protect cis people from making a mistake. They're not actually being person-centered and trying to listen to the person that's in front of them, look at them, talk to them, get to know them a little bit. And actually, you know, do they understand who they are? Are they worthy of treatment? Because this is who they are. And it doesn't have to be complicated. There's nothing that you're going to find that is going to be definitive. And the clinicians are looking after the cis population. That's how it feels to me. I don't know how you feel about that, Helen.
We've said that lots, haven't we? You know, it is not worth sacrificing one person's, one cis person's life who's making a terrible mistake by pretending to be trans. It's just not worth risking that person's voice breaking or breasts growing. And of course, this is not how I feel. This is how it's perceived sometimes. And I think it's a terrible way that time and time again we hear it being portrayed, and I feel embarrassed by any cis people who feel that their life is more precious than any other person's life. And I put that on the record completely. So what's the future, Noah? Let's if we were to pull down those people who have this power and cause harm, and we rewrite the rule book. What does it mean? So, let's get our crayons out and rewrite the healthcare rule book, written by a trans person who, an accidental ally, an advocate in the trans healthcare. What's the future?
In my opinion, the future is informed consent. And I'm not saying to pick mental health or psychiatry out of the field. I'm repurposing them. I'm putting them in a support role and not as a gatekeeping. I don't want psychiatry, and trans people don't want psychiatry to be playing God with our healthcare. There is a place for psychiatry when it comes to trans healthcare, but that's in a supportive role. That's in a role that can support trans people as we go on our journey, because, transition is difficult. It's, although it studies would show it overall improves our mental health, there are parts of it that's difficult. Some people's headspace changes on hormones. Going through surgeries is hard. It's tolling. So there is a place for psychiatry, but the place for it is not gatekeeping. The place for it is not deciding whether I am trans or whether I am not. It's in a supportive role. The way forward, as I said, is informed consent. It's taking trans healthcare out of a hospital setting. It's putting it into the community. We're not sick people. We don't need to be in a hospital. Our GPs can provide care. If my GP provides hormone replacement therapy to my mother going through the menopause, he can provide it to me. It's not much different. Care can be in the community because we're not sick. It doesn't have to be centralized to one clinic where people from the entire country have to travel to, even if they live 6 hours away. Our blood tests can be done by nurses in our GP clinics. It doesn't have to be done in a hospital. We want to be believed. We don't want to have to prove ourselves. We don't want to have to explain our sex lives and our sexual partners to people just to be given the hormones that we need. And lastly, I'd say that in Ireland, we have no surgery options. We have 0 surgery options for trans people. So any trans person that wants surgery must travel abroad, and most have to pay for it. So it would be, create surgery options in Ireland for trans people. For me, double mastectomy, which I had a year and a half ago, I think, in Poland. Double mastectomies are carried out every single day in this country by chest surgeons, plastic surgeons, on cisgender people, but they won't perform it on transgender people. So that's another thing I would change. I don't want to have to travel abroad for major invasive surgeries and not be entitled to any aftercare when I get home. I took my own stitches out of my nipples when I returned from Poland, and that's not good enough. It's not good enough for anybody.
No. Well, there you go. I mean, again, GenderGP written in a patient-centered way. And actually, no, I think one of the things we often talk about, what you've said, care in the community, care provided by general practice. That's what your mother or your father going through the menopause, because men have menopause too, their hormones drop off. They will be treated in the GP surgery. They'll have their blood tests treated in the GP surgery, and then they will get their hormones from the GP surgery. And if it's a bit tricky, then we will ask the local hospital to help out, if it's a bit tricky. But 100% this kind of care should be provided in general practice. And all it needs is a little bit of education and acceptance and belief that it's important. And the same with the surgery, Noah, so I don't think that someone who's used to doing female chest breast surgery can tomorrow use that technique on male chest surgery, but they can learn, and there's no reason why there shouldn't be some funding there for that education and learning to get that up and running. So we've got to have that education in there. GPs, surgeons, 100%. I'm just going to unpick that bit about psychiatry, actually, just from a medical point of view, because psychiatry is the discipline that deals with mental ill health. So things like depression or suicide or schizophrenia, bipolar disease, those kind of mental health disorders, conditions. And I think really what you maybe were talking about more is what Marianne's type of role is, the support for someone's transition and their journey and the difficult ups and downs that or the or the fantastic ups and downs that might be in front of them. And 100% agree with you on that support role. Whether it has to be given by psychiatry or whether it would be best to be given by psychology and counselling services. I would kind of challenge that, really. You know, a trans person would need a referral to a psychiatrist in the same way that a cis person would need a referral to a psychiatrist if they had a severe mental health problem that the GP couldn't handle, if you know what I mean.
I think when we talk about GenderGP, people come to us for care. When they're asking us about the model of care, the one thing I always say to them is you've got to make sure that this is the right model of care for you. And I wouldn't argue that a person-centred approach would suit everybody in terms of if somebody is so damaged that they're having a psychosis or they've got other, addictions or whatever. And it's got to be done as a joined-up approach, though. It shouldn't be you're trans, therefore you need to see a psychiatrist. It's actually what you need help with. But the reality is, overwhelmingly, even though, I agree completely with what you say, going through transition in and of itself is really difficult. We shouldn't minimise it, but the level of support that people need is different, and it can be done in the community. It doesn't need to be a referral to a psychiatrist, I would argue. And that's what we're doing it, aren't we, at GenderGP, really, in truth.
I think it needs to be a holistic approach to people's healthcare. So, your mind, your body, everything. But, here in Ireland, the National Gender Service, claim to take this holistic approach, but I don't think they understand the meaning of what the word means, because it's just, if you present as a trans person with autism, you're not getting treatment. If you present as a trans person who might have a history of self-harming, you're not getting treatment. It's not holistic. Whereas, if you present with any of those issues, the holistic approach would be to treat you at the same time as taking care of your other mental health issues, which is what we all would expect and what should be happening, not a point blank refusal or a point blank delay. I was recently an offer for a surgery referral was retracted from me only last week. Something to do with mental health, when I've never stated I have any mental health issues, which I currently don't or haven't had for some time. But it's all about corruption. It's all about the work I do. And there's nothing I can do to change that, because there's only one surgeon, or there's only one clinic in the country. So, what do we do when we get on their bad side? We can do nothing.
Yeah, you remind me when we were talking to Freddie O'Connell on one of our live broadcasts, and he was saying that he was a perfect patient. Absolutely, from the beginning to the end, he was your perfect transmasculine patient. He ticked all the boxes. He was a good boy. He didn't smoke. He didn't do any of those bad things. And everything was really smooth until the time he said, I want a baby. And then it was like, oh my goodness, everyone throw everything out of the pram and discharged him. So it's the same kind of thing, isn't it? So, perfect patients in you, but, oh, hang on a minute. Have you heard what he does? Have you heard the fuss he makes? Have you heard the trouble he causes? Oh, right. Okay. How can we punish you? It's really, it's terrible. But I think, what can we do? And I think what we definitely need to do is just not hold these things to ourselves. If people feel that they have been given poor medical care, nursing care, psychiatric care, if they think they've been harmed more than abused, then and abused more than helped, then there should be avenues, and each doctor, nurse, counsellor, psychiatrist is regulated by their own regulatory body, and they have a code of conduct which they have to adhere to. So sometimes, and I don't want to be the one that says that we escalate, take things further. But the courts are there to protect us, regulators are there to protect us. And actually what we need to do is share our knowledge of these things to help people get the care that they need. And then, of course, there's people like, who are doing an amazing job understanding both sides of it, because, it takes somebody with a flag and a couple of bottles of wine and 400 people in a protest behind them to start the march, isn't it? Which is clearly what you've done. And from what I hear, you've achieved a lot in since you started, your support group.
Well, I always say it's not just me; it's the entire trans community. I might have said a word, but I have an entire community behind me who are making change.
And I feel sorry, Marianne, as well. that some, Noah was saying that Ireland is very small, and so I guess that privacy is difficult, to be able to be in stealth or to be just quiet and just get on with your own trans life. It must be very, very difficult, particularly if you need the force of numbers behind you to affect change. And what if you didn't want to be one of those numbers? What if you just wanted to be one of the ones that just, melded into life easily? It must be very difficult, Marianne, to have that extra challenge.
The trouble is that, it's hard. We just talked before about the strains of transition, and then just talking to Noah, and we know at GenderGP how difficult it's made, and the fact that we're having to campaign and we're having to beg for change, and that we have to, not only do we have to prove our gender, then we have to prove that we're being marginalised, or, despite all the evidence. So I just think that continual drip feeding of point, if it's not the psychiatrist that's a gatekeeper, it's politicians or it's your GP. Do you know what I mean? It's just at every step of the way, it's like society's trying to make it hard. And I, for one, because I'm not an activist, I have to say, in any stretch of the word, I work in my own way, and I like to think that I bring something to the community. But my God, do I admire the people like yourselves, Noah, because it's hard enough without all of that, if you know what I mean.
Well, sometimes I just absolutely wish that I don't have to be trans Noah. I can just be Noah Halpin. I don't have to be the person that, when the newspaper's writing about J.K. Rowling, that I'm the one contacted. I wish that I didn't have to be known as the trans guy. I sometimes just wish I could live as just Noah, and no one knew, and my life would just be so much easier. Last night, for example, I had a meeting with a police station in Ireland. Don't worry, I'm not in trouble. It was all working. And I was waiting in the public gallery of the police station, and someone said to me, "Oh, Noah, how are you?" And I didn't know the person. I'll admit, I just didn't know them. And at that moment, I kind of said, "Do you know what? If I was in trouble, I would hate the fact that I am standing in this police station and people know me and know it." And even getting into the meeting with the inspector of the station, it was about trans people in policing and things like that. And he said, "Are you trans?" I said, "Yes." And he goes, "Oh, well, if it's any consolation, I wouldn't be able to tell." And I was like, I hate that now for the rest of this conversation, I am not Noah who is meeting you about policing when it comes to trans people. I am now Noah, the trans person, meeting you about trans people.
Yes.
Well, Noah, I'm not going to let you disappear just yet. I think, we need you, and maybe let's give it a few years, and maybe you'll get your wish to just subside back and be Noah the man rather than Noah the trans man. But the work that you do, I think, is too valuable, and I think there'd be a protest if you left. So, and I might lead it. So you're not, we're not letting you go yet. But what I do want to say is that we talked about the WPATH a little bit, and I just want to close on the fact that the WPATH are writing their version 8 of the standards of care, and I'm so excited for it. I hope that the voice of all the people that have put in their suggestions and committees, and the trans representation on those committees writing the chapters, are going to be listened to. I shall be terribly sad if they are terrified into not doing best practice person-centred healthcare. I'll be really sad if behind closed doors they write the things that we didn't want to see. But this time of writing, we do have trans representation. We do have more evidence, and I'm going to remain very, very, very positive and excited about the WPATH Standards of Care version 8, which we're waiting for. And I hope that it will give us that evidence base, Noah, that you've been talking about, to take to our GPs and our primary and secondary care, not this tertiary care specialist centre, but our primary and our secondary care, and say, here you go. Here's the rule book. This is how I'd like to be treated. This is what I need. Please, could you help me? And please don't judge me for being trans. And that is going to be the future. When it will be, I'm not quite sure, but that will be the future. I don't know whether you'd agree on that.
I hope so, Helen. And one thing I'd say is, if I can be my own doctor, having never gone to medical school, if I can read my own bloods, if I can read my LFTs and my hormone levels and all that, I'm sure my GP can do it. You know, if my GP can do it for every other cis person in the world, it's the treatment, it's, you know, the same reading of bloods. If I can do it for myself, you know, every doctor in the country can do it. And as you said earlier on, unless there's, you know, unusual changes or problems that arise, it doesn't need to.
Absolutely. Education and belief that it's their job and their role and their duty as a doctor to provide that care for you. And that's the little bit of jigsaw that's missing at the moment. And I think maybe in our campaigning, we should be fighting for those doctors and nurses and psychologists and counsellors that we do need to be accountable for their own decisions. And the decisions when they say no, how will they be held to account for saying no? Thank you so much for listening. I really hope you've enjoyed our programme today. Please go ahead and subscribe to future episodes if you haven't done so already. If you or anyone else have been affected by any of the things that we've talked about in our podcast today and you'd like to contact us, please visit our website Help Centre and contact us via there. We're very happy to accept ideas for future episodes and future guests, so let us know if there's anything specific you'd like us to cover. You can also visit our website gendergp.com for a multitude of information about transgender health and wellbeing issues. You can follow us on social media. ID is @GenderGP, and you can sign up to our monthly newsletter. Full details can be found in our show notes on our podcast page. Thanks for listening and see you soon.